Now, Fatima Madam will be dealing with the management of DRS cases. Over to you, Madam.
Thank you, Samyukta, for your very lucid presentation.
Very good evening. Earlier, speakers have covered the important aspects of DRS. Now, let us see the management aspect. So, already mentioned the importance of refraction even in DRS. Even DRS, you can have accommodative esotropia. So, it is better to have in mind. And when to plan surgery, better to avoid less than 5 to 6 years. Till then, you can tell the parent to maintain, allow the child to maintain phase turn, because let the binocular vision be maintained, so that sometimes some mother will be more anxious and correct, and the child will start suppressing one eye. So when to plan intervention? Whenever there is significant strabismus in primary position, or significant AHP, or significant globe retraction, or upshoot or downshoot. This is the classic ESO-DRS described in Rosenbaum, where there is equal to type 1 actually. No normal LR recruitment, only anomalous LR in up gaze or down gaze. So, here, like only here and here. So it gives a typical pattern kind of this way. So here abduction limitation is this much, but up gaze and down gaze the limitation is less. So this kind of pattern is seen only in DRS, not in LR palsy. In LR palsy, as already mentioned, the esotropia is proportionate to the amount of limitation, whereas in DRS the esotropia is very less, considering the proportion of the abduction limitation. So whenever we do a medial rectus recession, we should keep in mind the amount of co-contraction of the lateral rectus, because it influences in significant way. If it is mild, only 4 to 5 millimeter recession will correct only 10 prism ESO, whereas if it is moderate, it will correct 20% ESO, because your lateral rectus is acting against adduction. It is also pulling the eye outside. If there is severe LR co-contraction and you are doing the same amount of recession in a medial rectus, even the eye can go to abduction, to exo position. It is called a split, induced split. So that is a very important aspect we have to remember when we touch the medial rectus of the Duane's eye. So in case of esotropic DRS, first thing we have to, as already mentioned, clearly explained by Dr. Samyukta, we have to look for how much is the LR co-contraction, whether it is small, moderate or marked. How to diagnose anomalous LR activity? Already discussed whether how much is the globe retraction and upshoot or downshoot. Either it would be in the form of globe retraction or its equivalents. Equivalents are these upshoot, downshoot, or deficient adduction in opposite gaze, and DRS with split in extreme gaze. When the eye tries to adduct, the eye goes for abduction. So these are all the things already discussed. So again, forced adduction tests are also clearly described. Yeah. Romero Apis test, very good innovative technique to diagnose DRS. And this is based on Burton Kushner's advice, like for small, for esotropia with a small angle and a small lateral rectus co-contraction, we can go ahead with medial rectus recession, ipsilateral medial rectus recession. Whereas if the angle is large, definitely you have to look for this esotropia in opposite gaze. Already discussed this point. No, esotropia in opposite gaze will tell you how much the LR is working against MR. In the primary gaze, esotropia is more than 20 prism, okay. In adduction also, it should be some amount of esotropia should be there, at least more than 10 prism diopter. If it is less, you can understand, okay, in adduction, your lateral rectus is anomalously working, there is anomalous contraction of lateral rectus, so you can restrict the dosage. So if it is more than 10% diopter, you can go ahead with medial rectus recession up to 6 to 7 mm, but not in case if it is less than 10% diopter. If it is less than 10% diopter, better reserve very less recession for the ipsilateral eye and go with contralateral higher amount of recession. That is called asymmetric recession. This is a boy with 20-degree face turn and 30% diopter ESO. He underwent, because of the less amount of face turn and less amount of ESO, he underwent single ipsilateral 6 mm recession. There is not much co-contraction. You don't find that much co-contraction. But even then, you can find some minimal 5-degree face turn is remaining. So it is always asymmetric bilateral recession is more recommended than ipsilateral medial rectus recession. But in small angle, it is difficult to explain to the parents to touch the normal eye. For small angle with very less insignificant co-contraction, we can go ahead with ipsilateral MR recession. What is the mechanism? What is happening when we do asymmetric medial rectus recession bilaterally? This is the non-DSI, fixing eye. So we are doing more recession in the non-DSI. So due to fixation duress, more innervation to medial rectus is needed for fixation. And this inhibits the lateral rectus. What is the advantage of that? The lateral, it's due to Herring's law, this medial rectus innervation comes down. So so it helps to prevent contraction of the Duane's medial rectus, and there also you need not worry about more innervation to lateral rectus and eye going for exo, because this lateral rectus is already not working. So the benefit of this surgery is you get additional effect to prevent contraction of the medial rectus of Duane's eye. So what to do if the lateral rectus co-contraction is moderate? Then you can go for, you need to do, if you want to correct ESO more, you can go for 3 muscle surgery, bilateral medial rectus as well as ipsilateral lateral rectus recession. And also you can go for superior rectus transposition to lateral rectus. This is the one published by Dr. David Hunter, where he gives very good result. He advises medial rectus recession under adjustable, so that if at all some unexpected exo happens, we can adjust in medial rectus, because always it is in DRS, there is always a risk of getting exo after ESO surgery. So the way how it is done, the superior rectus transposition after medial rectus recession, superior rectus is, okay, this is the recession part. I will go to this. Yeah, superior rectus is secured. Then along the spiral of Tillox, it is embedded near lateral rectus. If the co-contraction is marked, then we have to remember, we have to do something for the co-contraction. Either we have to do Y-split, or you remove the effect of the lateral rectus by doing periosteal fixation. After doing that, you can combine with either transposition of partial vertical rectus or full superior rectus tendon to the lateral rectus to aid abduction. This is we already seen. So Y-split surgery we will see. So it's a very good rewarding surgery. What this FDT being is done, and yeah, lateral rectus should be separated nicely from the check ligaments, intermuscular septum. After securing as usual, then we are going to split the muscle in the center, and it will go up around up to 10-15 millimeter. You can use cyclodialysis spatula also to separate the muscle fibers. Yeah, as far as possible, you will separate the fibers. Then you will disinsert the muscle from the insertion. Yeah. In the recession, we have to measure the recession from the, first we are measuring the, how much we are going to separate the limbs, then we will measure the recession amount from that point, so that the limbs will be placed 20 millimeter apart. That will give a very good effect. Some books they say 10 millimeter apart, but it's better to go for 20 millimeter, or sometimes it would be very difficult to reach 20 millimeter. At least as far as possible, it should be symmetrically displaced. Yeah, other variants are there. These are also discussed. In case of a synergistic abduction, no other way. We have to deactivate lateral rectus by periosteal fixation. Then we can transpose. This is a Y-split pre-operative picture, and Y-split done in one eye, DRS eye, and had given good result of disappearance of upshoot and downshoot, and the face turn has also improved. And coming to XODRS will invariably will be associated with lateral rectus co-contraction, because the eye is in XO, LR is working. So orthotropic to less than 20 prism diopter exotropia, we can go for here we can definitely go for Y-split and recession of the ipsilateral muscle alone. If the exotropia is more than 20 prism diopter, we can go for bilateral lateral rectus recession with Y-split of the Duane's eye. Otherwise, even here we can go for periosteal fixation and vertical muscle transposition to improve abduction. This is a patient of exotropia where the unilateral lateral rectus recession as well as Y-split was done, and the patient maintained a good alignment. So this is the again for lateral rectus in contralateral eye, like how we mentioned medial rectus in the other eye. The same way, more than 20 prism diopter exo, we can go for other eye lateral rectus. Then how it works, the same way. But the important prerequisite is the good eye should be the fixing eye. If in rare occasion the Duane's eye may be the fixing eye, in that situation it's better not to, let me come to that in the further slide. So here we are weakening the normal eye's lateral rectus. What way it affects? It creates a fixation duress, so more innervation to act against normal MR in the primary position. This will, according to Herring's law, this will induce more innervation to the medial rectus also. And from medial rectus, this Harrington's law, this lateral rectus will be inhibited. So it prevents lateral rectus contracture and recurrence of XT. So this is the pre-op exotropia. Because the XT is large, here bilateral LR recession along with Duane's eye Y-split was done. So this is the periosteal fixation steps where we will, like that of normal lateral rectus weakening procedure, we will disinsert the lateral rectus and then separate periosteum and fix it in the periosteum with a non-absorbable suture. This video is not that clear. We will fix it with the non-absorbable suture to the periosteum, and we will be carefully closing the fascias and tissues over the, so that the lateral rectus will not come into contact with the globe again. So with this Y or lambda pattern, again it's like a pseudo Brown's. Here to differentiate from inferior oblique overaction, one has to look for minimal abduction limitation in the primary gaze and look for other findings of inferior oblique overaction. Always surgical confirmation is whenever you operate on Duane's eye, the important difference is when you, the lateral rectus, both the muscles will be very tight. The lateral rectus also will be very tight. When you cut the muscle, the eyeball will become soft. Because all the while it was, the eyeball was caught in between the tight muscles. No, when it was released, the eyeball will become little soft. That is a normal sign. And surgical confirmation, the beneath the tight lateral rectus, the sclera will be blue. So these are all the confirmative signs of Duane's eye. So to correct the lambda pattern, LR recession with upper transposition can be done. Instead, bilateral superior rectus recession can also be done. In the textbook it is given, we don't have experience. And fixation with DSI, we should be very careful. Sometimes the Devan's eye would be used for fixation. In that occasion, if we operate on the Devan's eye, due to fixation duress against already existing restriction, there will be unexpected outcome in the other normal eye. Usually what will happen when the eye fixates with the DSI, the fellow non-fixing eye will fall or rise in its outward rotation. It will not be like upshoot or downshoot, but it will behave. Behave in a more bizarre way, where the normal eye will fall or rise. But the Devan's eye, because the Devan's eye is good eye, it is fixing against restriction. Here maybe we can try improving the amblyopia in the good eye and improve the fixation, then go for any intervention, or we have to remove the lateral rectus power, like go for lateral rectus deactivation procedure and then decide. Bilateral DRS with fusion. Sometimes the patients will have nice fusion in the primary gaze, or with little face turn they will have fusion and bilateral DRS. It's best to avoid surgery. And maybe a small face turn can be corrected with prism. As rightly said, the lesser the surgical indication, the greater the likelihood of post-operative complications. So because it is bilateral DRS, we need not operate if the patient is maintaining BSV with little acceptable anomalous head posture. But if without fusion, we can try surgery. If it is bilateral ESO DRS, we can go for bilateral medial rectus recession, and EXO same LR recession with Y split. For ESO, after recession, depending upon other co-contraction, you can already discussed, you can go for transposition procedure. This is a bilateral DRS patient where there was cosmetically disfiguring upshoot and downshoot were there. So we went ahead, and large EXO was also there. So we went ahead for bilateral lateral rectus recession with Y splitting. So after surgery, anyway, we have to explain the patient, we are not going to expect any improvement in abduction. Rather, we are going to expect the upshoot and downshoot disappearance. So to summarize, establishing the type of Devan's and individual role of lateral rectus and medial rectus, its innervation is very important. And also we have to look for the secondary muscle change. As already discussed, the main important thing is whether the lateral rectus works normally and whether the lateral rectus works abnormally, whether it co-contracts, and whether the medial rectus has gone for secondary muscle changes. These are all the important deciding factor to decide the dosage of surgery. And address the indication of surgery, patient counseling regarding residual deficits, and plan the type of surgery depending upon the type of presentation.